And again, I apologize, we didn't get to everyone's questions, but at the lunch break, you'll have a chance to descend upon Dr. Gandhi and ask him yourself. Now we are going to do a little pivot and try and keep everybody's attention as you become progressively hypoglycemic as we approach the lunch hour. And we're going to do some interactive cases. So leading us in this endeavor is Dr. Mike Saag. You met him once already. He's a professor emeritus of medicine, microbiology, and public health at University of Alabama, Birmingham, and leader of the Scenics cohort, one of the pioneers in HIV-related treatment, and one of the funniest people I have ever met. As you are about to find out, if you don't know already, is a huge fan of the Broadway musical. And so you might notice some tunes that will punctuate the audience response questions as we go through these. But please, we look forward to playing along with Dr. Saag.
Thank you, Rafi. Thanks. Hello. That is a hard introduction to follow if your build is being funny. Oy. So usually what we've done is just had a random selection of music, and I thought I would channel it more just to two shows that I've seen recently here that I recommend is Ragtime and Two Strangers Carry a Cake across New York. So that'll be our music. The second thing I'll say as initial disclaimer is that I'll get into this more in a minute, but how the cases are determined, some of you have asked me that, and I'll go through that. But first, let's introduce folks on the panel who you haven't seen yet, but you will see later today. Dr. Eaton, who is a professor at University of Alabama, Birmingham, and specializes in infectious diseases, substance use, and also does an HIV clinic, and Dr. Melanie Thompson, who will be talking to us about vaccines later, and she's in Atlanta and private practice, and has done primary care HIV from a time when it wasn't popular to do primary care, and now she's highly in vogue and will be talking to us about primary care and vaccinations later. So I don't have any financial relationships. These are the learning objectives. We're going to talk about initial therapy, switching, what to do when someone becomes pregnant while on Cabrolpivirine. We'll get, there were some questions about that earlier. Pre-exposure regimen that failed, liver, not LIBOR, but liver fibrosis, discordant CD4 count, MPOX, and CAR T-cell therapy, which we're seeing a little bit more of. I will be calling on a couple of the audience members, I'm looking at you, Jason, to talk about some of these with the panel. As you know, those of you who have been to the course a lot in the past, this is standard, and from year to year I do change the questions, and if I don't change a question, it's because the answer changed, and that happens a lot. But what I'm really doing is I'm watching, one, what's happening in the clinic where I work, what types of challenges are we experiencing, and I bring those. Secondly, I get questions a lot from either audience members at one of these events or phone calls, like what do I do with this person? And then thirdly, I sometimes recycle an entire question from a couple years ago just to see if the messaging is continuing to resonate and if there's been any change. So let's go ahead and get started. This is a question, the way I format this is I have a question that orients you to what you're about to see so you're not struggling to take in the information, not knowing where I'm going with this. So this is about initial therapy. 48-year-old guy presents, newly diagnosed, asymptomatic, moderately high viral load, low CD4 count. Other labs are pretty normal. You do have a genotype, so I'm making this a little bit unnatural because oftentimes when you start therapy you don't have a genotype, but I'm going to guide us a little bit with that. We have an M184V, normal renal function, no significant history, and he wants to start therapy. I'll let you go through, but there's a series of things here, either a TDX, XTC, TXF, and dolutegravir, a fixed-dose bictegravir regimen, a fixed-dose dolutegravir regimen, cabotegravir starting right now, and then some other variations within it. And I threw in the islatravir, doravirine. And I think hopefully it's appreciated that when these courses are organized, it's not like just individual faculty sending in their slides and that's that. There's pre-conference conversations on Zoom about what are you presenting. So there actually is coordination. And then the night before, last night, we got together and talked about what's what. So there should be some continuity from one talk to another. And in this talk in particular, I'm deliberately repeating some things you've already heard just to kind of bring up some of the nuances from the data that go flying past you. So hopefully by now folks have voted, and we're in ragtime. Yes, good. You got to see that. It's here till June. It's awesome. I see people saying, yes, it is awesome. Okay, let's see where we are. Okay, so the majority, this reminds me of 2007 when everybody used fixed dose efavirenz, TDF, FTC. You remember that? Yes. When it was kind of the green monster, it took over Manhattan or something. So let me start on the end with Dr. Rana. Do you agree with the audience? I mean, a lot of times you'll do this because you don't have a genotype, but take us through your thinking on this question.
Yeah, I agree.
To the mic.
Oh, sorry. Yeah, I would agree that probably that would be the regimen I would reach for on the list. Fixed dose, well tolerated. We have data on its use in people who have an M184V mutation, even if they're not, suppressed sort of at the point of switch. So I think it would be a really good option. I do think that, a tenofovir containing regimen with dolutegravir also would be an option in that case. I'm, cab and rilpivirine in this setting in someone who you don't know necessarily yet in terms of a direct to inject. I think there are some studies looking at that approach, but we don't necessarily have that data. And 3TC dolutegravir as an option, I think could be a bit of a challenge with the N184V, but again, we have, some data looking at that as well.
Yeah, good. Dr. Landovitz, let's say you are considering something other than the standard. Is there do you think there's a wrong option up here with the data you've been given so far?
Well, you haven't told us Hep B status.
Hep B is immune.
Okay. So if you know that they're Hep B immune.
To the mic a little more.
Oh, sorry. If you know that they're Hep B immune, so you're not concerned about having a non-tenofovir containing regimen, I probably would shy away from option C, because you'd essentially be giving dolutegravir monotherapy, and we know from the data from that agent as monotherapy that it might hold you for a little while, but ultimately there's an increased rate of failure. So I'd be less excited about that one. And I think, in 2026, you'd really like to avoid something that contains a booster.
Yeah.
So I would, unless I was really forced into a corner for some reason, would avoid something that contained either ritonavir or cobicistat.
So let's take the M184V away and say it's wild type virus. How do you feel about dolutegravir 3TC fixed dose in that setting?
Well,
and hepatitis B immune.
Yeah. I think there's a bell curve of opinions on that. There's people with excellent commands of the data who think that it is an outstanding regimen, and the data increasingly support that in this kind of person, it is likely to be just as good as a 3-drug regimen. And then there are people who are more married to the idea of a 3-drug regimen, despite this very robust data, and just feel more confident with a 3-drug regimen.
So there are people who need people, and what type of people are you? Are you one of the luckiest people in the world?
I'm one of the luckiest people in the world.
Yes, and so what would you, personally, which camp are you in?
Personally, I like the TAF FTC BIC regimen, but I know that that is not a data-driven response. That is an emotional response.
Okay. And there were original data, right? When dolutegravir 3TC first came out, it was restricted to people who didn't have lower CD4 counts, et cetera. Then there are data that have come up since then that said, it's pretty good. So you're not going to go wrong, right? Dr. Eaton, let me bring you in. Let's say this is a patient who's quite different, in a different socio-dynamic, and they've been struggling with substance use disorder for years, and finally somehow someone decided to test them at age 48, but you're concerned about their ability to adhere to a regimen. How would you go about you're seriously concerned about that. How would you go about thinking in this situation?
Yeah, hearing this thread,
To the mic.
this does sound a lot like many of my unfortunately new diagnoses. Often it's someone from a criminal legal system in Alabama.
There you go.
You've seen the case. They often have hepatitis C co-infection. In my clinic, where we focus on integrating HIV and addiction care, we do use option B most commonly. I will say it may be our emotional support ART, as Dr. Landovitz referred to, but we do use a lot. We see it is very effective. Of my patients who can come into clinic and take this medication, I would say I haven't seen any challenges with it, tolerability or failure. Everyone seems to do well. I will say there's a whole nother group who's not able to come to clinic, who does not actually adhere to clinic. That is a bigger challenge. And then just one other point, in hearing Dr. Gandhi talk about islatravir, doravirine, I do think oral once-weekly options do have a role in patients like mine who are also coming in clinic weekly because they need close monitoring, peer counseling, housing nutrition, lab draws, and buprenorphine is being administered weekly. And to me, that was a connection I hadn't made before, but that is an option for that group who's coming in weekly for social support. And I think I was encouraged by that oral weekly option in the future for my patients.
Yeah. Raj, let's go to the drug that isn't available to us, but soon will be, islatravir. You got a question about that earlier, almost in anticipation of this case, but would this be a case with the 184V that you're okay with islatravir? That's going to be an emerging controversy.
Yeah. I'd be a little worried about islatravir with someone with M184V. I don't think we have enough information to be sure. Dr. Richmond is sitting in the audience, and I think there are emerging data on islatravir, this NRTTI, that causes some question around M184V. If they didn't have M184V, then this islatravir, lenacapavir weekly in the future, which we don't have, I like that idea if they didn't have on M184V. With M184V, I would be hesitant. I would use probably the one that most of you use, bictegravir FTC TAF. Yeah. The study that has gotten us a little bit more confidence with dolutegravir 3TC with low CD4 counts is the Dolce study that looked at people with CD4 counts of less than 200, 2-drug therapy versus 3-drug therapy, and people did well with dolutegravir 3TC. But I'm not convinced enough that you can use it with M184V. There's some observational data, but I'm worried about monotherapy, and so I wouldn't use dolutegravir 3TC with M184V.
So this is where I phone a friend, and Dr. Richmond is sitting in the front row, and there's a microphone, but the resistance panel, I think, it just published or they're about to, another update. Yeah. Is it silent on this issue with islatravir, or what are they saying?
We discussed the lack of data. So there's a paper that the mutations group has put together and should be coming out within a month or so in the IAS-USA journal. And,
topics in HIV medicine.
And we go through all of the susceptibility issues and so on with the various drugs. It turns out that the M184V mutation confers a reduction in susceptibility, but it still is a picomolar drug
Yeah.
with the M184V mutation. And the achievable levels are still significantly superior, but there are no data. And
Right.
so there's some compromise, but it may not be enough to make a difference. But you can't make a recommendation without some data.
Yeah, we don't have clinical data yet, so
Right.
you all put it as a question mark, or?
We discussed the fact that there are not
Okay.
enough data to make a clinical decision, but there's some reason that it may still be a good drug.
You're thinking it might still have activity enough?
Right.
Right.
I
Not going to
think
use it
some
as
of the people who
monotherapy.
develop resistance on islatravir doravirine, it's possible that some of them develop M184V, and that would also give me pause. And so, so we'll see. Stay tuned for this
Yep. Thank you.
this breaking story.
It's great. Okay, I'm going to move that there's guidelines that Dr. Gandhi is the chair of, and there'll be hopefully another iteration coming up soon. So, should I switch from a successful, complicated regimen to something simpler? And you saw some data just now in Dr. Gandhi's talk. So let's look at, this is a very, I think, real-world scenario, because it came from my patient. 68-year-old, diagnosed 35 years ago. Current regimen is boosted darunavir twice a day, TAF-FTC once a day, and dolutegravir once a day. Up to 2010, it had poor adherence, but then suppressed for the last 15 years or so. Remote genotype data is available, but it's incomplete in a retroviral history, and someone ordered a cellular DNA that showed M184V, K103N, and multiple PI mutations, would like a simpler regimen. I went back and dug out a formal resistance panel that doesn't look pretty, and it has maybe some increased susceptibility to tenofovir, but resistant to most of the non-nukes of old days, et cetera. So, would you keep him on his current regimen? And this is all, I'm going to assume that all of these data, all these drugs, are available to you now. So you should vote as if you have these medicines in your hand, because you will by this time next year, if I'm lucky enough to get invited back, and I'll update the slide. But so you got current regimen, once daily dolutegravir based, the standard fixed dose of bictegravir, bictegravir lenacapavir, you just saw a study on that presented. Islatravir doravirine with dolutegravir, or some other option. Go ahead and vote. This is the opening song of Two Strangers. It's fabulous. Yeah.
Mike, this is Journey On from Ragtime.
Yeah. All right, we have some. Raj, you did a great job presenting. Looks like there's a lot of folks who bit on that that bait that you threw out. Dr. Thompson, have you ever seen a patient like this in your practice?
Never, never.
Of course you have. What do you think? To the microphone, please.
Well, you know, I have to say that I think the artistry studies are very interesting, and exactly this kind of a patient falls into that category. So I would be comfortable with Vic-Lin, you know, understanding that we don't have long-term data with that, but I think we have a fair amount of data. So I think that's a very reasonable choice. Could you get by with Vic-TAF-FTC? We don't really have much about the patient's history, but since they had been on this regimen for 15 years or so, I'm going to assume that they didn't have a lot of integrase failure in the past. And Raj talked about the studies that reassure us in terms of nuke resistance. Maybe TAF FTC would work, but there's a lot of nuke resistance there, so it makes me uncomfortable to use that option. And I think staying on the current regimen, well, he wants to simplify, let's try to do that for him. Islatravir, DOR, again, we have the questionable amount 184, K103N shouldn't affect DOR, and dolutegravir once daily, still more complicated. And then, you know, so basically I think Bic and Lynn is a reasonable choice for this person.
Okay. Raj, you reviewed the data.
Yeah, I agree with Dr. Thompson.
Agree with
That this will be the sweet spot for that drug, is just this kind of patient. Probably C and even B, so the bictegravir FTC TAF, for the reasons mentioned, and the dolutegravir FTC TAF. We have glommed on to bictegravir FTC TAF because obviously it's one pill, the other one is 2 pills, but both, I think, have the same,
Yeah, so
profiles.
I was listening carefully to your answer to one of the questions, or it was like it set up this whole talk, actually. But you were talking about the studies out of Africa, et cetera, but there's no tenofovir resistance that we see of any sort in what we have available, and there's no integrase resistance as far as we know. So you're going to have 2 pretty fully active drugs. There's a lot of good options here, but I think the take-home point is that because of the history and that ugly-looking phenotype, what we saw, we sort of tried to keep, it's like an inertia effect, but I think we're starting to see that we can get some people off of these wacky, complicated regimens that they fight through every day. These are data that you weren't shown. This is from the paper that Orkin et al. Had in Lancet, and you can just peruse it. I'm not going to walk through it too much, but it's a gamish, right? I mean, it's like a mess of things, but it's so real world that, to their credit, they did this study and allowed very liberal entry criteria, which helps it be applicable to real world situations. I wrote an editorial for that paper, and I put this comment in that Lancet didn't have a sense of humor, and they took out, because my point was people with HIV on complicated regimens would rather switch than continue to fight through these horrible regimens. So they didn't like that, and I didn't like that they took it out, but I threw it in here. Let's spend a moment talking about DNA resistance tests. It was ordered in this case. Did it help? Dr. Howe, do you, in your work looking at transition of women to babies that are born, do you ever look at DNA resistance? Does that help you, or in your setting?
No, and you're right, the young adults who had perinatally acquired HIV and are heavily treatment experienced.
Yes.
It's always difficult to dig out all of their old resistance mutations, but we typically do the phenotyping.
Yeah.
Yeah, I've not gotten the proviral DNA data yet
Yeah.
to guide my clinical thinking.
All right, I'm going to make a provocative statement and then see, then I'll say I don't find it useful. It makes me uncomfortable on both ends of the interpretation. I worry about mutations that may be present that were missed, but I'm more worried about mutations that are reported that are on archive viruses that are not replication competent. This is a wonderful article from the same group that Dr. Richmond's a part of, and it basically goes through the great detail about why these DNA assays are useful only in select situations. Doug, can I ask you to come back and say, just a simple question to you, in your practice, if you have a situation like this, do you order a DNA genotype for any situation, or does it help you, and how do you interpret it?
No, I agree with the people on the panel. It's doing a test that may be less informative than you hope it is. And just very, very briefly, the reasons are severalfold. One, the viruses may not be replication competent, or if they are, they may be in a location in which they're not readily activatable. There are a number of mutations listed there that reflect APOBEC mutations, which means that the virus is basically non-replication competent. But other issues are that from a few lymphocytes that are collected to do DNA typing, the actual number of interrogated proviruses is actually quite small. So there's a selection bias for a very small subset of what is in the body of the patient. And so there's a number of reasons why the actual results may not be that useful.
So thank you. And I like your answer because I agree with it. But it is, in seriousness, it's an attractive thing, right? Because you don't have plasma viral load to look at. It's all you got, but sometimes it can be just as misleading. Okay, that was the point. All right. This we've already talked about, I think 2 times already, but I wanted to bring it home. A 48-year-old guy presents with newly diagnosed HIV, 4 months ago, asymptomatic, started on dolutegravir TAF-FTC. I made the same viral load and CD4 count. Other labs were normal. Genotype in that setting was wild type. He asked if he can simplify to a long-acting injectable, and now he's undetectable HIV and a CD4 count of 270. The question is, with regard to chronic HBV, which of the following, and I apologize for the question, it was in your pretest, but should not start rilpivirine? Just say that's a bad idea. So you've got the choice of surface antibody, core antibody only, surface antigen, HBV DNA less than 1,000, or you really shouldn't start anyone in this setting who has evidence of any type of HBV. Go ahead and vote. So if Evelyn Nesbitt was on the panel, I would ask her, but she's not on the panel. Okay. Okay, so we don't need to spend much time on this. That's the correct answer. I think for interest of time, I'm just going to move on and say, because we've already had some discussion about this, the antigen is the thing that really can get you in trouble. There's especially antigen positive, surface antibody negative. That's where you're going to get the highest breakthrough. And these are data that they weren't published yet, I don't think, but the key is right here. Never antigen, always antibody, very low, and that's what Dr. Gandhi was talking about earlier. But if the antigen's positive and you don't have antibody, you can have up to a 10% chance of a significant reactivation, and that's the take-home point. At CROI, there were a couple of posters that I think are represented here. This one's from the OPERA cohort that I'll draw your attention to the upper left, high risk, which is basically antigen positive, antibody negative situation. And again, that number about 10% in that sort of salmon colored box for reactivation, and for flare it was about 5%, and that was a good take-home point. And this Hazer study, Dr. Gandhi already reviewed with you, and I think you just train your eyes to the right-hand part of the screen, and the numbers are low. So I think we raised this question, I think, together in a case that I brought 2 years ago, and I think we were, kind of jumping around and doing a dance, but now there are more data, and it's better. Dr. Thompson, before we leave the topic, the question came up, isolated core, you would vaccinate, right?
Absolutely.
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 With which product?
Well, come to my talk.
Okay, all right, you're going to hear which product, Peposlav,
the short
and
answer
so
for
she'll
those
go
of
into
you
that. And okay, well, that's good.
Peposlav. I
Yeah,
would use
would you
Cephalexin.
wait? Would you, this came up, would you just wait before you switched, or would you just go ahead and switch, give the vaccine, and move on?
You know, I like Raj's answer, it depends on the person, but, I would go ahead and give them the vaccine. And then, I think if the person is comfortable waiting, it's only a month, you can give them the second dose. But if they really, really need to start now, then I would feel comfortable going ahead. And you're going to get them back in a month anyway to see how they're doing and finish up at least that 2-dose series.
Yeah, so if you have the luxury of waiting, sure, and if you feel more urgent, you just move on, right?
Yeah.
Common sense.
And we'll talk about the details later, so come to the talk just after lunch.
Okay. Well, look forward to your talk, because there's a lot of important information. What regimen should I use in a pregnant patient? So, 30-year-old woman, 6 weeks pregnant. She was diagnosed 2 years ago with her first pregnancy, but during her pregnancy on oral therapy, she was not terribly adherent. And in fact, at delivery, her viral load was 22,000. They did all the things you've just heard about from Dr. Howe, and the baby was not infected from that exposure. She's now on rilpivirine cabotegravir every 2 months, doing well, as you can see. Her other labs are normal. So now you got a decision to make. Would you continue the rilpivirine every 8 weeks? Would you take it to every 4 weeks? She's in her first trimester now. Would you switch to one of the recommended regimens that you've already heard about? Go ahead and vote. Two Strangers, first act, about third song, thereabouts. Fourth song, fourth.
And
I'm getting
seriously,
paid a
if you have
commission by
not
these two
seen this
shows
show,
to
go.
get people to go. Okay, not. All right, so Dr. Howe, you were very effective in your communicating earlier, but I don't think you went into what dose. So what dose?
So in pregnancy, right, you don't have the luxury of waiting to see if there's a little viremia. Right now, because of the other data in non-pregnancy, to be conservative, we would use the every 4-week dose. Yeah. And that's what the PK study will be looking at when it comes out later this year, is monthly
Good.
dosing. Yeah.
And what do you anticipate it's going to show?
I think it's going to be fine. Now, it's not, it's not going to answer the question of pure safety, right? You have to enroll thousands and thousands to look at that, but PK-wise, I think, yeah.
Raj?
Oh, I would agree. I would do every 4-week rilpivirine, but I would do first, though, is just go back and check as to whether her circumstances now are any different than they were 2 years ago. It's possible that 2 years ago, her life circumstances were such that she wasn't able to adhere and had the viral load of 22,000, but it's also possible that things have changed, and maybe bacterial FTC TAF, where we have a lot of data, would be okay. So I would have to do that, and then if her circumstances are the same, then every 4-week rilpivirine.
Yeah, so we could have some shared decision-making with the patient about whether she wants every 4 weeks or not. I think it's safer. Aadia.
Yeah, there was, I think what we have in terms of, modeling data for in pregnancy right now does support every 4 weeks. But, she's been stable on every 8 weeks and has been doing well. And I think it would be something to consider, probably with more frequent monitoring in this case. So, then that would argue if she's coming in more regularly for viral loads, why doesn't she just come in for injections? But that data was presented at CROI this year, about 24 patients who were already stable on rilpivirine, so not initiating, had been stable, became pregnant, and were continued through delivery. I'm sorry, I think it was 15, not 24, and did well in that way. So certainly, as I think Jennifer said, data coming, but there have been case series on reporting its continued.
So let's say she's in your patient pool, and you're going to continue on, and your vote would be based on everything you've seen so far, more frequent monitoring, but continuing her on her every 2 months. We don't have any evidence that the PK changes at the last trimester, although other regimens have shown to have some issues, but you're comfortable with that right now?
I think it would be something to consider. I mean, I would share with her that this is what modeling data shows. This is Q4 weeks. And if they're, she's unwilling or says that doesn't, fit
Okay.
what I want to do, I think we would certainly continue. I wouldn't stop it in that case.
Great.
I mean, I would say anecdotally, we have had 2 women. They were fine on every 8 weeks. They blipped on the every 4 weeks. Not huge. Yes, yeah. So one went to about 80. The other one was just sitting around 65, but came right
Yeah.
back down. And the adherence is fine because they're coming, so not big.
Yeah, I think it just got angry because of all the pain in their buttocks from the extra injections. So this we've already kind of reviewed, and the key part, this is from the HHS guidelines. It basically blesses what we just said, and they throw in terms, I think, like shared decision-making, some other stuff like that, which is important to kind of have that. And they hedge and say continue this with viral load monitoring every 1 to 2 months. And I think, so it is a major change in what we were saying 2 years ago, right? So I wanted to make sure I brought that up. All right. Someone has been on rilpivirine and the regimen failed. 38-year-old guy on viral load rising on that regimen. Previously had been on BIC-TAF FTC for 6 months and then switched over. I didn't say how long ago, more than a year ago, switched to rilpivirine every 2 months. Had the lead-in, hadn't missed a dose. His last dose was 2 months ago, and you detect his viral load now is 280. It had been less than 50, and the repeat is 360. His CD4 count is 850, so he's in pretty good shape, but there's some integrase inhibitor resistances at 148 and at 263. So now the question is, what are you going to do? So go ahead and look this over and vote. This is from Ragtime, and Cassie Levy is remarkably good. It's good just to go see her and Joshua Henry. It's like going to see just in time to see Jonathan Groff perform. You don't need a story, but the story's great. Okay. All right, we're going to journey on. Interesting. Okay, so audience is smart, they're thinking. Dr. Landovitz, what do you think?
I mean, I like the idea of someone trying to continue a long-acting option and thinking about Len in that setting. The best data that we have for Len in heavily treatment-experienced people is with a fully optimized background. And I mean, I guess you could make an argument that TAF FTC should be fully active here.
Should be.
So it would probably work.
Yeah.
But if they're going to have to take daily orals anyway, unless there's a drug-drug interaction or tolerability standpoint, or, so I'm not hypocritical in saying that you should avoid ritonavir and cobicistat containing regimens. I don't dislike F in this particular case. I think, E is an interesting question. The genotype sort of suggests reduced susceptibility to BIC, so you might have some anxiety about it. And then the other issue is, what about the TAF FTC BIC issue in this particular case? And Dr. Rana zipped through these data a little quickly, so you might have missed it, but there's now a Canadian case series of people who failed rilpivirine in the treatment context with mutations not dissimilar from this. And They were treated with second-generation integrase containing dual nucleoside regimens, and with modest durations of follow-up, these 5 people are maintaining virologic suppression. So I think the million-dollar question that we don't know the answer to, so it makes it hard to make this a generalized recommendation, is phenotypically, what do these people look like, even though the genotype might predict resistance to BIC and dolutegravir. And I think we don't know the answer to that, but I think we're going to talk about this in the PrEP failure context. This is one of the big unanswered questions. When you have someone who gets an integrase resistance genotypic profile in a CAB context, can you salvage those people with dolutegravir or bictegravir? I think we all currently, based on the lack of robustness of the data, would have anxiety about doing so, but I think it's an unanswered question.
Okay, a quick.
It's important to say that the study that I showed you on bictegravir, lenacapavir, that actually excluded people who had integrase resistance. So today I would use TAF-FTC boosted darunavir. I think that's the one that he's going to do well on, and then monitor for future drugs. But that's what I would do.
Okay. Let's talk about therapy in the setting of PrEP failure, PrEP regimen failure. A 28-year-old guy who was newly diagnosed, had been on TDF-FTC for PrEP. Not sure what the adherence was, but HIV was detected by an antigen antibody test and the viral load modestly up. Other labs are normal. Resistance test shows an M184V and a K65R, and okay to start therapy. This is now challenging this dogma we've been hearing about all morning that, yeah, the nucleoside regimen part of it doesn't matter, and we'll see where you guys think after hearing all that. And our big question for the morning is to the point of there is a thin line difference between what's dogma and what's dog manure. Let's go ahead and vote. This is the end of Act 1, and they got an American Express car they're going crazy with. It's really exciting to watch. They go manic. 2 strangers. Okay, let's see what Bonnie and Clyde would do here. Interesting. Okay, we are working on the assumption these drugs are available. Who wants to take this one? Anybody? Yeah. Raj, you're leaning forward.
Yeah. So we spent a good part of the morning saying that switch studies have shown that dolutegravir plus TAF-FTC or bictegravir plus TAF-FTC should keep people like this suppressed. So there's a hierarchy, right? The hardest people to suppress are the people who are viremic. Then the next highest are people who are suppressed already. So in people who are suppressed already, I think
it works.
It works.
Yeah.
The closest data that we have for this patient is a study called Aadia that came out a few years ago, which took people who were failing NNRTIs like efavirenz and randomized them to either get boosted darunavir or dolutegravir with TDF-3TC. And both groups did well. 90% of the time, people did well. And they had a lot of resistance because they did resistance testing and they had these kind of mutations. 90% of people did well with either a boosted darunavir plus TDF-3TC or dolutegravir. But there was about a 4% rate of developing integrase resistance with dolutegravir. So 4%, it depends on your risk tolerance. So the most reliable for someone like this is probably E, which is dolutegravir plus boosted darunavir, but that comes with, some issues. Or is it there? I don't see it, but or you could use TAF-FTC and boosted darunavir. That would be the most kind of the safest.
Yeah.
I'm sorry, you told us he has, he doesn't, the only resistance he has is just the nucleosides, just the one?
Yes, just the nucleoside.
Yeah. So that would be the discussion I'd have with him is, There's a small, 9 times out of 10, he'll do well on the regimen that people like, TAF, FTC, bictegravir, but there's probably a small chance that he'll develop resistance.
I think that's fair, and that's kind of what I wanted to get to. Your colleague, Paul Sachs, I've heard him speak a lot. You all probably know him well. He liked that Aadia study so much that I think he named his dog Aadia. You can quote me on that. Okay. Oh, sorry. I added this question really for Dr. Landovitz. What regimen would you use if this was a failure of CAB prep with a Q148H? Let's go ahead and vote quickly, and I'll let Dr. Landovitz. So he was on CAB prep, the regimen fails, comes in with a resistance mutation to cabotegravir. Let's go ahead and vote. Yeah, this is father coming back in Act 2 in Ragtime. He's singing about the music of Ragtime. Not that you're really that interested. I'm just trying to kill time while we vote. Okay. All right. Most people feel comfortable. What would you do, Rafi?
You know, I think, again, this is an unanswered question. I think we're hoping that TAF, FTC, BIC will ultimately be the right answer. I think a lot of people still have an urticarial reaction to using BIC or dolutegravir with a Q148H mutation. I think we've got a growing body of evidence, some from HPTN 083, which was the registrational trial of cabotegravir, which was, of course, in terms of its treatment choice, when people did break through, CAB was not randomized, but there were similar rates of virologic suppression in people on a bictegravir or dolutegravir containing regimen compared to mostly PI-based regimens. And Urvi Parikh and Kate Koss's cohort from UCSF, called the SeroPrep cohort, now has 7+ people in it who have acquired HIV in the context of CAB use, many with mutations like this. And their strategy was to induce people to undetectable with a PI-containing regimen and then switch them to a dolutegravir or bictegravir containing regimen, which Mike and Raj alluded to as a strategy that you could have used in the tenofovir-based PrEP failure before. And I kind of like that.
So that's what I wanted to get to. What would you do in this setting? Because you ran the studies and you encountered this. What would you do?
So that's what I would do. I would put this person on a boosted PI regimen, probably, it's not here, TAF, FTC, boosted darunavir, until they were undetectable, and then switch them to either a dolutegravir or a bictegravir 2-nuke regimen.
Okay, that's fair. Yeah, I like that.
So Mike, I would just point out that our current guidelines in this setting would recommend the TAF or TDF XTC plus a boosted darunavir regimen. So that's not actually a choice there, but that is what our guidelines now say.
Right. Okay. So real quickly, we'll dive into liver fibrosis. We've got a 45-year-old guy who's been on BIC-TAF FTC starting 6 years ago when he was diagnosed, doing pretty well. He had hepatitis C that was cured with direct-acting agents, but he still has significant liver fibrosis. So this is really on the edge of where our knowledge is, or as HIV providers. But the question here is, would you choose, which regimen would you choose? Would you just continue to observe him and fibrosis gets better? There's a drug called mestreptopron that's a TH inhibitor, receptor agonist, thyroid hormone. Then semaglutide, and a couple of other options is FGF21, or other things you can't pronounce. And the point is, I think if you were interested in this, you'd probably refer to the hepatologist. Just go ahead and vote, and we'll talk about it. There's a point to the question.
Mike, hangover duet opening to Act 2, Two Strangers.
Yes, that is. That's. All right, so that's a good segue to semaglutide. That was my point, that I don't know what half these other drugs are. I know the hepatologists are working with them, and I'm not going to use it because I'm not a hepatologist, I don't know the drugs, but I do know semaglutide, and there was a study at CROI, or New England Journal recently, that showed that semaglutide actually improved liver fibrosis in some patients without worsening of their non-alcoholic steatohepatitis. And this study that Scenics put out at CROI showed reduced FIB4, which is the fibrosis. Look at that bolded middle line there, and it was pretty significant. And so my whole point is, it's a commentary, because I wanted to get Frank Zappa with us today. But if you know the album Apostrophe, the end of side one is a song called Cosmic Debris, and every time I see the semaglutide data, I flash to with the oil of Aphrodite and the dust of the Grand Wazoo. He said, "You might not believe this, little fella, but it'll cure your asthma too." And I said, "Look here, brother, who you jiving with that cosmic debris." But it really is, semaglutide is like curing everything. I mean, I don't know what it doesn't do. Does it even substance use, Dr. Eaton? I mean, it's everywhere. And I also think Frank Zappa looks pretty cool. I thought a slide with him would be nice. Okay, this is going to be quick. This is a test of like 4 years ago. I had this case. What I do with the patient with discordant CD4, person started on boosted darunavir 4 years ago, which is probably not very realistic. I think this is the case from 4 years ago. We don't do this much. Had good success, but the viral load came down. The CD4 count barely doubled over the course of 4 years, and she's doing well. What are you going to do? Continue the current therapy, change the nukes, go to an INSTI, add fostemsavir, add IL-2, or something else. Go ahead and vote. That's a fun song. Go Hortzog. Okay, what a game. Okay. All right. Some folks would change. Let's see. Dr. Thompson, thoughts? Would you change this person?
Not for that reason. I
Okay.
would stay the course.
All right, yeah, so
You
we
know,
talked
if
about
the
getting rid of the
person-
booster. So maybe that's what people were thinking. The bottom line is, I was trying to re-emphasize biology, that this is what we hope to see when we give antiretroviral therapy. The viral load, the lower part, goes down, and then the upper part, CD4 count goes up. Great. But there are people who get the bottom, the viral load goes down, but the CD4 doesn't. And that's just biology. For somebody who came in typically with advanced infection, meaning that their CD4 counts are low and the viral load kind of high at the beginning, at least my interpretation of the data are that a lot of CD4 cells are trapped inside of lymphoid tissue, and when you stop the inflammation with antiretroviral therapy caused by billions of viruses produced today, that when you stop that, those cells get released, and that's that first 6-week bump in CD4 that some people just don't get. But if you focus on the right-hand side, that slope of CD4 count increase after that bump is roughly the same. So it's really not about antiviral therapy. It's about biology, and there's not much that I've seen yet that can increase the CD4 count in that setting. IL-2 will increase it, but what does it mean? And it's also toxic. And fostemsavir people are alluding to, but there are no data in this setting that it would do anything. All right, how do I treat Mpox? 30-year-old male presents with new lesions. You see them here, his buttocks, groin, back, and face. He's MSM, he's febrile, he's sexually active. His viral load is up because he's been off for a little while of his antiretroviral therapy. CD4 count here, he uses as a UDS for methamphetamine. A swab is positive for Mpox. what's the best approach to treatment? He's pretty sick. He needs to be hospitalized. He's really an extremist in terms of his just uncomfortable and not feeling well. Okay,
So again, two strangers, finale, it's snowing.
it's snowing.
Go.
And if you're in the third row, like Rafi was, you got snowed on, which he found very exciting. Okay, I'm going to ask another audience member, Dr. Zucker, to come up, because he's the one who brought us the bad news that Tacovirimat didn't work. So what would you do? Is there anything that works?
Not that we know of. So we're certainly.
Okay, thank you very much. No, I'm kidding.
I mean, we're certainly in a data-free zone. What we do know is that patients like this do very poorly. So we certainly have great data from Chloe Orkin and the group out there that put together sort of the global case series, demonstrating that people with lower CD4 counts and higher viral loads do really terrible when it comes to Mpox. So we want to try to do something for this person. I think we showed the data earlier, but monotherapy with Tacovirimat I think is out. There's really no indication that monotherapy with Tacovirimat will make a huge difference at all, and so I would not do that for this person. You know, we have hope for Tacovirimat plus brincidofovir. That hope is the same hope we had once upon a time for Tacovirimat. It was approved through the same process, and so we don't have a lot more data, but I think that's certainly something I would try for somebody like this, because we don't have sort of other options as well.
Okay, thank you. It's tough, and so I think the Dion, go ahead. Dr. Richmond.
The most important point from Dr. Richmond is restarting his antiretroviral therapy, because we know that is the one thing we can do is helping them recover that may help improve.
Okay, cool. Because I was stuck in Burt Bacharach and Dionne Warwick here to say a little prayer for you. And fortunately, most people pull through, but it's not pleasant. Okay, final case. We have a case of virologic failure after treatment of lymphoma with a CAR T. This is actually one of my patients. 58-year-old guy was diagnosed HIV 25 years ago. He'd been through the usual stream of regimens, and he's currently on Big TAF FTC. His viral load had been less than 20 for over 20 years, less than 50, I mean. He was diagnosed, he came in with a very large mass in his neck, and I said, that doesn't look right. And we sent him over, got biopsied, and it's a B-cell lymphoma, which he failed his anthracycline therapy. So he was given a CAR T-cell infusion. 6 weeks after his CAR T-cell treatment, his viral load spiked. What's the likely cause of the spike in viral load? Adherence issues with his medications, drug-drug interaction with chemo, false positive viral load test, poor absorption of his ARV because of divalent cations or some other reason, superinfection with an HIV-resistant strain, or radiation exposure from an Iran nuclear facility bombing. Let's go ahead and vote. It's our last song. Tata. I could just sit here and listen to that. It's so great. Joshua Henry, amazing. Okay. All right. All right. Drug-drug interaction. You got this one, Raj? Does anybody know the answer? There is an answer.
I've heard of false positive viral loads with CAR T cells. I've not seen it this high, 67,000, but because you use these lentiviruses to make CAR T cells, you can get a false positive viral load with that.
Yeah, and as the yellow light came on, ding, 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 so Aadia knew that, yeah. I mean, it's one of those things you either know or you don't know, but we're starting to see more and more CAR T cell therapy, and just kind of keep in mind exactly what Dr. Gandhi just said. So they use a lentivirus vector that's rich in long terminal repeats. To remind you of that, that's a schematic of the HIV virus. On each end is a long terminal repeat. And these LTRs are used to transduce T cells with the receptor target genes that they want. Importantly, the Roche-Cobas Amplicor assay targets that LTR to measure viral load, and so it picks that up. And you're right, I didn't really know what his viral load, he was already at NIH, and they called me saying that his viral load was elevated, and had he been adherent? And I said, yes, but I don't remember what, it was probably 6,700, but that's the point. And that if you get into that situation, of course you're going to continue the antiretroviral therapy. If you want to see what the viral load actually is, you can use the Abbott real-time HIV viral load that targets the polymerase gene, which is that sort of rusty color area, not the LTR, and you can get a more accurate thing. So I thought I'd leave you with something a little bit different. Maybe you've heard that before, but if you haven't, now you hopefully know it, and my mission might be accomplished. So wrapping up with 51 seconds left, ARV therapy should be initiated with an integrase strand transfer inhibitor-based regimen as close to the time of diagnosis as possible, of course. And chronic HBV co-infection with hepatitis B surface antigen positivity is a relative contraindication for non-tenofovir-based regimens. We talked about that. Use of non-INSTI regimens in the setting of CAB failure for PrEP, it's doable, and we should maybe try that. I think what we heard was get the viral load down, and then you can go back to an integrase regimen if you'd like. GLP-1 agonists have become Frank Zappa, and they can be used for almost anything, it feels like. There are downsides, of course, in terms of GI motility issues and maybe muscle sarcopenia, so it's not all perfect. Cellular DNA genotype, not terribly helpful, so I think we confirm that at least for today. Maybe we'll come back in 3 years and that dogma will have gone from dog manure back to dogma. We'll see. Discordant CD4 counts happen, nothing to do. Mpox has limited treatment options. And I didn't ask you, Jason, but it was demoralizing for us. I think it was probably 10x demoralizing for you, having put the study together. And yeah, gosh, I'm sorry. And CAR T cells are made with a lentivirus. It can cause false positive viral loads, and that's that. So thank you very much, and we'll have a few minutes for questions. I think maybe just 10 minutes or 9. So do we have point-of-care viral load tests?
I know there's a number of companies working on them. It would be great to have point-of-care viral load tests. Remember RADx from the COVID days? They actually have a program to try to develop point-of-care HIV viral load tests. I think there's a meeting, someone told me in April, someone else on the panel may know, to try to pull together all the information on point-of-care to try to make a leap forward. But so I don't think we have it today, but I think there's progress on it. So.
I think the closest thing we have right now is gene expert platforms can run viral loads, but it's got a low limit of quantification of 400. So, you know, depending on what you're trying to do with that, that may or may not be good enough. I think that's the closest we have at the moment.
I think the gene expert is less than 80. If you dilute it, then it's less than 80. But it's point of care in the sense that you still got to wait a couple hours. So,
we don't have a home test yet.
Right. Yeah.
We've got HIV antigen tests, maybe. But yeah, it's going to be hard because it's PCR based, and that makes it more difficult. What about, I'm sorry to throw this at you, Rafi, but it's a question from Daniel asking about lenacapavir injection site reactions. You ever seen one of those?
So, as Raj was talking about in his talk, and Dr. Bookbinder will talk about a little bit later, right? When you inject lenacapavir, which is 2 1.5 cc subcutaneous injections, the drug forms a depot in the subcutaneous tissue. So you expect there to be a nodular presence of that depot. There's a bell curve of people's reactions to that depot. Some people say, that was nothing. Why did you even bother to counsel me about it? What's your problem? Some people say, that's mildly uncomfortable and it goes away fairly quickly. And some people say, you're never doing that to me again. And I don't think we quite know how to predict who's going to have any of those.
So I forgot the second part of the question, which is, does it help if it goes in the somewhere other than the abdomen?
So I don't think we know that yet. There's still a fairly small number of people who've had anterior thigh, which is the other FDA-approved location. And then in the purpose trials, and Susan will talk about this more, it was also allowed to be given in the subcutaneously in the gluteal region and also the back of the arm. It doesn't yet have regulatory approvals for those injection locations, but I don't think we know the adverse event profile of those alternative locations yet.
Right. So stay tuned. Dr. Eaton, in your practice when you're using buprenorphine, which we're using more and more fortunately, what are the drug-drug interactions or the things you try to make sure to avoid, or if anything, when you're using that?
Very few, and we do address these in the IAS-USA guidelines and talked about it last night. I think there is a lot of appropriate concern about drug-drug interactions, but the general takeaway that we want our audience to appreciate is that active substance use and safe meds for opioid use disorder, specifically buprenorphine, are really not a contraindication to many of your other evidence-based tools for patients with HIV. Hepatitis C treatments are safe in this population, vaccinations. So buprenorphine really has been transformative for so many of my patients because they can continue to get all of the other HIV treatment prevention, et cetera.
Yeah, so that probably came from one of us like me who's got PTSD from dealing with methadone.
Yep.
Like, wow, what do I do with this? And so, yeah, that's been an issue over the years. I think that's what we have. Oh, one question about the difference between a flare of hepatitis B versus a reactivation. Are you going to go into that at all, Melanie, in your talk? Not really?
No.
I mean, I'll give it a shot, and you guys can correct me if I'm off base. But a flare is basically somebody who's got chronic hepatitis. It's going on, and then you take away the cover of the tenofovir suppression, and there's actually a flare in liver enzymes where they can go up as high as tenfold. And I guess rarely can cause liver failure, but mostly it's just a scary thing to watch. Reactivation is, remember that hepatitis B goes through cycles, can go quiescent, and then it kind of comes back with antigenemia, and I think that's really how I would differentiate. Did you all agree with that explanation? Okay, but you're right. In these slides that I showed quickly, we have it boiled down to flare versus reactivation. I didn't explain that, so I apologize, but hopefully that makes it clear. And I will turn it back over to the chairs. Thanks, panel. Great job. Thank you, audience, for hanging in there. Okay, Dr. Landovitz.
Okay, so I wish I had something intelligent to say at this moment other than it's lunchtime. We're back from lunch at 1:40 p.m., so please nourish, hydrate, and we'll see you for this afternoon for the remainder of this very exciting program. Thanks for your great engagement online and in person, and we'll see you in a little bit. Thanks to our panel, thanks to Dr. Saag, thanks to all our morning speakers, thanks to the weather for not getting worse.